That's good.
All right, so we're live. I just want to first off thank Dr. Wagner and Gottschalk for allowing me to bring home the lecture season for you guys, and I'm excited. You know, Tom and Joe are graduating. Our topic tonight, CMC arthritis. It's relevant for everyone. It's incredibly common and it's controversial. As I'm sure you've seen in your different rotations, you'll see multiple surgical approaches. And in the literature, you really won't see one dominant technique over another. So I think it's important to kind of know. My goal today is to kind of talk about the foundation as terms of anatomy, pathophysiology, the treatment, the evidence. So you're kind of armed with a way to kind of think about things and realize ultimately different solutions are best for different patients. A little technical issues here. So, you know, this is actually Dr. Wagner's line, but I do want to thank my mentors. You know, Tom, I was in your shoes 2 years ago, and I can't tell you what an incredible year it was and how it shaped my life. I can tell you I have changed some of my thoughts since then, as early experience will also shape your kind of influence in what you do. But I can't be grateful enough for this foundation and know that as you enter the Emory family, you'll be giving this talk next year. So I'll give you my slides. These are my disclosures. They aren't relevant to CMC arthroplasty. So let's talk about basilar thumb arthritis. It's common in the fact that it's the second most site of arthritis in the hand. It's the most common site of arthritis that's surgically treated. It has a female predominance, as I'll tell you, mostly due to ligamentous laxity. And it's controversial because there's multiple treatment options with no clear evidence of one technique's superiority over another. And as you go, you'll see, yeah, technique is more of a matter of religion than science, what works best in your hands. But there's also considerations that as you enter practice become relevant, such as implant cost, anesthesia availability, and other things, right? So you have to kind of find what works for you, for your patient, and in the system you're operating in. So our trail map today, we'll talk about kind of the biomechanics, the anatomy, the pathophysiology, how I like to work these patients up, treatment options, some of the outcomes looking at 10,000 feet in randomized controlled trials, some emerging techniques that are kind of popular at the meetings and have growing evidence, and then draw some conclusions. So when we think about the anatomy of the CMC joint, we have to kind of start with history. The thumb is critical. It's 50% of hand function. If you look back to the ancient philosophers, you know, it was the thumb, in addition to reason and speech, that separated us from animals. And the word trapezium is derived from trapeza, which means altar. So in a sense, the trapezium is really the altar of the hand. And what makes it so special and unique is its arthrology. We know it's a saddle joint, but what's less understood or appreciated is that it's a saddle joint in two planes that allows for this multiplanar motion and this interesting paradox between instability with freedom of motion, but also the potential for instability and potential arthritis. When we think about the ligamentous stability, we're indebted to the work of Bettinger and Berger, who looked at the 16 ligaments that actually stabilize the thumb. Now, the three I just want to focus on today are the dorsal-radial ligament and the volar beak ligament, as they perform a force couple that reciprocally tighten during the arc of opposition, and then the intrametacarpal ligament. These are the key ligaments that become altered and can lead to arthritis, and also are the main targets for reconstruction, whether you're using an autologous tendon or a suture button. This is what we're trying to recreate, is this force couple that allows for motion, that allows for, you know, freedom, but also provides stability. So let's talk about function. We already said the thumb is 40 to 50% of hand function. It allows for prehension or grasp. And part of the setup for arthritis, or what makes it so common, is that, you know, there's this 12 times force multiplier at the CMC joint when you pinch something. So you have this inherently unstable joint that allows you to oppose and do all this incredible things that lower primates can't. But then when you pinch something, there's 12 times the force generated through. So you have this kind of heavily loaded joint that's inherently unstable. And then also, you know, when you think about shear stress, it's 2 times. So there's some intrinsic stability from a ligamentous standpoint, although the thenar muscles can be protective. When we think about the biomechanics of thumb opposition, we call it the screw home torque mechanism. And this is kind of how that delicate balance or interplay between instability needed for motion and stability needed for power pinch come together. You have the volar beak and dorsal radial ligaments working as a force couple, where at rest, the CMC joint is lax and incongruous, and the volar beak and dorsal ligaments are lax. However, as you begin to oppose and abduct the thumb, you have the metacarpal beak that articulates with the trapezial recess and kind of locks in, creates that stable pivot, and allows, the volar beak to be lax and the dorsal radial ligaments to tighten. And when that gets disrupted is when you start to have asymmetric loading on the joint and eventual arthritis. So let's talk about the pathogenesis. It's multifactorial. Ligamentous laxity certainly plays a role, obviously trauma, but for most of the patients we'll see, it's degenerative. And it's just this progressive rotational shear and compressive forces during power pinch that lead to cartilage loss. And if you look at the pathophysiology, which starts out as pain and synovitis and dorsal radial subluxation, then you develop osteophytes and adjacent carpal arthritis, and then this compensatory MCP hyperextension. Well, these observations, which are found not only clinically and radiographically, are what form the basis of the Eaton-Littler classification. And so, as I'll describe, we see these patients in clinic at the entire spectrum. And I think it's important to know the radiographs, know the pathogenesis, and kind of know where patients are on that spectrum so that you don't rush to surgery and you pick the appropriate treatment. So most patients are going to complain of pain at the base of the thumb. For the older patients, it's, opening a jar, it's pinching. Early on, they're not going to have an obvious deformity. And I think it's important that, there's a high incidence of carpal tunnel and other pathology in the hand. So you can't just rush to CMC and stop there. You really have to examine everywhere. They'll complain of difficulty with fine dexterous tasks like writing and scissors. And over time, for advanced disease, you'll see the Z deformity, which is a product of adduction and dorsal subluxation from the adductor pollicis, and then compensatory hyperextension from the pull of the EPB. On exam, we all are familiar with the axial grind test. That's fairly specific, meaning if they don't have pain with that, they're unlikely to have arthritis. But it's not great at detecting disease. There's a traction shift test, which sometimes we do unintentionally, but that's the opposite. So instead of compressing it, you can pull on the thumb and almost like a pivot shift of the knee, try to pull it out dorsal radially. That can be very sensitive. Obviously, they're going to have objective decreased hand strength, but I think the key thing is to examine the joints adjacent to the CMC. So the STT joint, as you'll see, a lot of the failures in this surgery, I can cut to the chase here. There's a meta-analysis that says there's 4 or 5 techniques with equivalent outcomes. Where I think we sometimes miss the mark is we fail to identify adjacent carpal disease at the ST, and that's why patients can have persistent pain, because the radiographs don't always show you that, but sometimes on exam, patients will have that volar pain over the STT, and that just kind of clues you into intraoperatively, make sure you look at that articulation. And then, carpal tunnel syndrome is concomitant with CMC arthritis, as well as other sided or sources of radial sided or wrist pain. When we look at radiographs, kind of like a partial thickness or degenerative rotator cuff tear, if we got, x-rays of everyone's hands here over 40, there's going to be some arthritis there. And at the end of the day, you treat the patient, not the x-ray. In fact, a third of postmenopausal women have radiographic evidence of CMC arthritis, and everyone, if you live long enough, develops CMC arthritis. So death taxes and CMC arthritis are things you can count on. And these radiographs don't always correlate with pain. You treat the patient, not the x-ray. I personally just get the standard AP lateral and oblique. That usually gives me enough information. Sometimes on standardized tests, they talk about Roberts and Guetta's view, which are the true AP and lateral, but I personally don't get those routinely. So we talked about the Eaton-Littler classification. That helps to describe where the patient is on that spectrum or on that pathogenesis. But as I kind of alluded to earlier, it does very little in terms of it's very unreliable with correlating with symptoms. We see patients that come in with distal radius fractures where you can see horrible CMC arthritis on the radiographs, completely asymptomatic. I think the more common scenario I see is the patient that comes in with debilitating CMC arthritis, perhaps a female in her mid 40s with very little arthritis. And what do you do with that patient? How do you manage them? And the pathophysiology, as we said before, starts with inflammation. So this is a stage 1. You actually have widening of the joint, then narrowing, then osteophytes and adjacent carpal disease. Always start with non-surgical treatment, and the evidence to support this, especially in early diseases, is very good, 76% effective. Now, I think it works obviously better in earlier disease, and I almost always do it in conjunction with something else, usually a steroid injection. Topical anti-inflammatories, they do have some evidence to support them. I think that in itself, they haven't been as effective in my practice. There are some activity modifications like using larger diameter pens. And as I said before, steroid injections tend to work the best at earlier stages. So if you look at the graph to the right, upwards of 80% in Eaton stage 1, but it drops kind of precipitously as the disease becomes more severe, because it's not just an inflammatory problem, it also becomes a mechanical problem once you develop osteophytes. There are some newer treatments and some biologics with growing evidence. They aren't covered by insurance, but for completeness sake, PRP actually does have a randomized control trial showing superiority to steroids at 1 year. Synvisc or hyaluronic acid also has some evidence of efficacy, and there's some thought that it may be chondroprotective, but it's not covered by insurance. And some of the studies are confounded by other things in the injection, like Toradol, so it's hard to really to know if these are really superior or not. I personally refer these injections for ultrasound guidance. I was humbled to see that, Dr. Stern did a study in which he just blindly tried to do a CMC injection in a cadaver that took an X-ray. And with his experience, he was still only 50 to 75% accurate. And so I think that sometimes you can definitely, in some patients, if you can especially have an assistant apply traction, it's much easier to get into the joint. But ultrasound definitely increases the accuracy. There is a clinical sign that was described at our institution by Dr. Grindel, in which if you inject the CMC and it extends the dorsal capsule, you'll see this thumbs up sign, which can help confirm you're in the right place. So let's talk about surgery. We're surgeons here. Hopefully this will spur some interesting debate. In my mind, there's really 3 different categories. There's trapezial sparing approaches. Usually the goal here is to maintain trapezial height. These are younger patients in which strength and power is more of a priority. These involve kind of more minimally invasive strategies such as arthroscopy, also volar ligament reconstruction with hemitrapeziectomy, metacarpal extension osteotomy, and CMC fusion. There is the simple trapeziectomy, which is kind of the minimalist approach, which, we've all seen patients with subsidence after, but the literature clearly shows that that's the most important part of the procedure. And then there's this trapeziectomy plus, which whether it's a pin, whether it's a suture acting like a pin that stays in forever, or a ligament, FCR, APL, some biologic, or an arthroplasty, hemi or total. These are kind of more advanced procedures that think that trapezial height matters, preventing subsidence matters, and recreating stability matters. If you think about it, a trapeziectomy is kind of a girdle stone of the thumb, and yet it's crazy to think that performs just as well as anything else. But we've really yet to find studies that at 5 and 10-year outcomes outperform it. What are surgeons doing? This is old data. This would be a good Emory study to repeat with more modern techniques, especially with the rise of certain technologies. But Dr. Wolf in 2012 surveyed the ASSH and found that LRTI was far and away the mainstay of treatment. 62% of members use this as their preferred technique. Fast forward 6 years at the AASH. While LRTI was still the most common, we started to see a rise in suture-based materials, rather a suture suspension or a suture button suspension plasty. And when you ask surgeons, why do you do what you do? They say, well, the most common answer was, that's how I trained. I learned it in fellowship. And do surgeons tend to change? No. So we tend to, go to fellowship, see multiple things, and find a technique or a mentor who gets great results, and we don't tend to change. Trapezial sparing techniques. So we'll talk about arthroscopy. This is, the benefit here, it's minimally invasive. Historically, you use the 1R and 1U portals. If you're just doing a synovectomy or capsular shrinkage, you can also use the D2 portal. And as Dr. Wagner will tell you, look out for that radial artery branch. That's right there. So you have to be thoughtful when you dissect. And in addition to doing a hemitrapeziectomy, you can also do autologous or acellular dermal matrix interposition. Wilkins did a systematic review in 2018, kind of looked at 10 studies using arthroscopic techniques, and found that, overall, these improved pain and DASH scores, modest improvement in grip strength and pinch. There are very few complications, but the question was, what was the long-term reward? Was there still pain? Did these patients eventually develop ST arthritis and need revision? There wasn't long enough follow-up to really answer that question. I think as this becomes more popular, hopefully we'll be able to answer that. I think the ideal patient is someone that's younger, Eaton stage 1 or 2, where a minimally invasive approach and a faster recovery is a priority. Interestingly, there was a study that compared arthroscopic to open hemitrapeziectomy without interposition, and they found that even though arthroscopic was fancier, less invasive, pretty much the same outcomes, right? There's no difference in pain, functional outcomes, satisfaction, complications. So the question is why use, an arthroscopic tower and a camera when you could make a 2-centimeter incision and be done faster? This is, using arthroscopic hemitrapeziectomy using a tendon interposition. I know that, in our fellowship, we did a few cases with acellular dermal matrix that had excellent early follow-up. I did not see them long-term. In addition, there's volar ligament reconstruction, or the Eaton-Littler procedure. This is one of the first kind of trapezial sparing techniques published in the 70s. So it's a 50-year track record in which you resect the distal trapezium, and then you use FCR to kind of recreate the volar beak ligament. When you looked at long-term outcomes, which in this study were only 7 years, it worked excellent for early arthritis, stage 1 or 2. But as you got into stage 3 and 4, your outcomes in terms of good or excellent did decrease. And so I think the question is, why? Is there adjacent STT arthritis that wasn't identified? That's kind of the big question with all these less invasive strategies, is are they as durable? The extension osteotomy. So when you look at the force couple mechanism, as I said before, that screw home torque mechanism, the stability when you oppose the thumb is that first metacarpal, that volar kind of pivot point. So the force generally with opposition is in the volar aspect of the CMC. That's where it wears down. So the thought is, if we could do an extension osteotomy 20 to 30 degrees, could we shift, kind of like doing an osteotomy in the knee with someone with medial compartment arthritis, can we shift those pressures to the dorsal aspect of the CMZ to preserve the joint, and get patients, basically you certainly maintain trapezial height if you don't remove it, and can you get some pain relief and durability there? And when you look at these patients 12 years out, what's interesting about this paper is they were doing this and fixing it with pins. I think nowadays we would use a low profile plate. But there was a high incidence of pin site infection, but 70% of them didn't need additional surgery. And so this is something I think to consider if you had a young patient with post-traumatic arthritis, with predominantly kind of volar wear on the cartilage, but certainly only Eaton stage 1 and 2. Once you start to get osteophytes, there's going to be mechanical symptoms and pain that will not be improved just by redistributing the force. Arthrodesis. So this is a technique in which, good results were demonstrated in the short term. This was more for the laborer, someone that was very high demand, someone that you were worried about having painful subsidence or required kind of power pinch and stability. Now, the trade-off here is that the hand was never going to be able to lay flat. So this is not the procedure you do with the laborer who also wants to do yoga, or that would be a complaint, in your hospital and affect your PROMIS scores. But for the high demand laborer, especially post-traumatic, this was a good option, and historically it was done with a plate. It's durable, but the concern is adjacent carpal disease. Now, if you looked at these outcomes, fusion rates were high, although it sounds like they're higher now, but in this paper it was 50 to 100%. But the problem is that you'd get STT and MCP arthritis. Whether or not that was clinically relevant was controversial, but you did see that, and that was one of the main concerns: durability, and then how you salvage it after. Take the plate off, resect the trapezium, and then put a big allograft. I did a few of those salvage procedures during fellowship, and they can be a bear. So I think the best patients are, 40, laborer, high demand. And you just have to warn them about potentially having adjacent carpal arthritis later. This is Dr. Rizzo's study, which is now 15 years old, and he found that there were 13% non-union rate, 9 reoperations, and 30% showed progressive arthritis radiographically, but a very small percent were symptomatic. So one of the themes in CMC and why it's controversial is we don't really have good metrics that matter, right? You can't look at subsidence because, as I'll show you, subsidence is incredibly common and oftentimes asymptomatic. And you can't look at necessarily adjacent carpal arthritis because oftentimes it's not symptomatic. I think ultimately it's power pinch and patient satisfaction and normalization of thumb mechanics, which we're still trying to get a handle on measuring reliably. So let's talk about simple trapeziectomy. This is the minimalist approach. This is the approach if you own your own surgery center, because there's no implant costs and it can take 20 minutes. Now, the biggest knock to this approach, which is truly just removing the trapezium, closing the capsule, immobilizing, and getting them moving around 4 weeks, is this whole Blix curve concept. So if you lose the height of the thumb and the flexor tendon or all the tendons lose their tension, the thought is you're going to lose power. And so the subsidence can lead to impingement, laxity, and weakness. But when you look at kind of the biomechanical and the clinical studies, we've seen from Downing et al. That first metacarpal subsidence doesn't actually correlate with pinch strength or with patient satisfaction or pain. And we've seen with randomized controlled trials that when you compare trapeziectomy and trapeziectomy with LRTI, the outcomes are the same. And so I think there's some issues here. I think the converse to that is, okay, look at the revision papers. So patients that undergo revision CMC surgery, what was their index procedure? I would say in our group in Milwaukee, oftentimes it's a simple trapeziectomy in a patient that comes in with subsidence. And so subsidence usually doesn't matter, but sometimes it does, which kind of complicates this. I think in a high demand individual or someone with ligamentous laxity, like your rheumatoid or inflammatory arthritis patient, I'd be leery of just doing a trapeziectomy because I'm not sure the remaining ligament or capsule is going to be strong enough over time to prevent subsidence. And you will see that first metacarpal writing on the scaphoid. And over time, I think that does generate a problem. Trapeziectomy plus, this is a huge family of procedures, but the first really in this is Dr. Meals, UCLA, where after doing a trapeziectomy, would put a pin across the first metacarpal for 5 weeks. He had 92% pain relief. He had improvement in grip strength, only to 47%, but it was better than his previous LRTI results. And so here you are comparing a procedure in which you're harvesting a tendon that takes longer, has a longer recovery time, and you're putting a $3 K-wire and pulling it in clinic. Downside, pin site infection. Other downside is long-term results in subsidence. Very similar to the other techniques. Ligament reconstruction, tendon interposition. So this remains the most common operation even today. And this technique has evolved over time. So Eaton Littler in the 1970s used the FCR for your pure ligament reconstruction to recreate the volar oblique ligament. And then later, the trapezium was excised and the intermetacarpal ligament was reconstructed. And then Thompson used the APL as opposed to FCR. Froimson then added the anchovy interposition component. And then Burton and Pellegrini combined the benefits of the Eaton Littler and the Froimson and did an FCR for not only ligament reconstruction, but then also as a bumper to prevent subsidence, made an anchovy. And then the Wheelby procedure, which similar concept, is using the FCR slip, our own FCR and APL to create a sling, kind of like you would just use with the suture suspension now, instead using an autologous FCR graft. The reason why this is the most common is that, if you think kind of conceptually as to what matters, stability and preventing subsidence, this addresses both. and it addresses both with an autologous tendon, which is thought to stand the test of time. And I say thought to stand the test of time because when you look at the literature, you still see the same subsidence rate even with the tendon interposition. So the question is, what's happening to that tendon? But nonetheless, some of the biggest series with these show at 9 years, 95% excellent pain relief, good grip strength, good pinch strength. But as I said, even when you take the time to harvest the tendon and you put a big anchovy in there and it looks great at 2 weeks, 6 weeks, 3 months, 6 months follow-up, over time, you will see loss of trapezial height. It's usually not clinically significant, but it can be. And what you do next, we'll kind of get into salvage. An interesting question is we know removing the trapezium matters. Do you need the interposition? Well, this was examined in JBJS. They compared ligament reconstruction or just simple trapeziectomy with LRTI, and they found absolutely no difference in pain strength, daily function, dexterity, and really no difference in proximal metacarpal migration under stress. And so it seems that the tendon interposition, as logical as it seems, didn't really influence the outcome. And subsidence also didn't seem to influence satisfaction or function. Do you need the reconstruction? Here's a study kind of prospectively comparing hematoma distraction arthroplasty to LRTI with follow-up that was very highly variable, 5 to 18 years, but still long-term follow-up, which really showed no difference. What about FCR harvest morbidity? You know, everyone talks about the benefit of some of the newer technologies is not having to spend the time, not having to worry about, FCR harvest morbidity. What is it actually? Well, if you look, actually, it's very, other than, local hematoma or nerve issues, there is a clinically insignificant loss of wrist flexion extension torque. So if you're, consenting a patient in clinic, for an LRTI, and you say we're going to harvest your FCR tendon, I mean, you can tell the patients, clinical studies have shown wrist flexion, although is somewhat weakened, it's not clinically noticeable. And I think what's also interesting is that there's studies that have looked at the FCR on MRI after harvest, and 64% of patients have partial tendon regeneration. We'll talk a little bit about trapezium metacarpal arthroplasty, and honestly, I'd love to hear Dr. Wagner's experience, especially with the European experience, because this has become more popular, especially in Europe where it's approved. And it's not a new idea. It's been around for 50 years. The first generation of implants had high rates of loosening and periprosthetic ossification. And the issue is usually on the trapezial side. Newer designs are better. But philosophically, we have the issue in our country as to how can we spend money on an implant and a procedure that's high risk, expensive, when a simple trapeziectomy is shown to be as good as anything else. But I think it's interesting when you look at the studies looking at the biomechanics, if you are replacing the joint, you are maintaining height and you are allowing, more normal thumb motion. And I think there's great results in Europe. We just haven't really seen them here yet, certainly due to some of the barriers, economic and FDA wise. But the initial generation had a high incidence of revision, which I think has been improved with more modern designs. When we talk about hemiarthroplasty, so this is the Stabilix implant from Skeletal Dynamics. This built on some of the previous failures of basilar joint arthritis and the fact that you maintained trapezial height. You got rid of some of the trapezial issues with the total arthroplasty with loosening. And it's this saddle-shaped hemiarthroplasty that has a little extension moment for stability. The outcomes short-term are very good, but again, this is a very expensive implant. It does have a learning curve. And if it goes south, rather infection or implant fracture, or needs to be revised, it's hard to justify putting a patient through this when a trapeziectomy or a trapeziectomy with a, $20 fiber tape or for a suture suspension performs just as well. Implant interposition arthroplasty. So over the years, many biomaterials have been tried. The reality is many of them have ended up failing. I think any CMC talk, and when we talk about all the innovation, and you go to the meetings, Artelon was an implant. It was a porous polyethylene implant in 2005, with the thought that you could just resect the trapezium and put this in as an inner position that would help prevent subsidence and stabilize the thumb. And this was a disaster. It was a biomaterial that reacted with the body, had a 37% explantation rate. And so this is an example of a product that tried to replace technique with technology and ended up kind of backfiring. So when you look at all implant-based treatments, whether it's pyrocarbon spacer, some type of Artelon or polyurethane, they have a much higher failure rate, much higher revision rate. So I would use them with caution. I think the latest wave in CMC treatment is using sutures rather than a suture button or suture to lasso the tendons to prevent subsidence. The first iteration of this was the test procedure, which is trapezium excision and suture suspension, which was an anchor placed. I think what's interesting about this paper, which is now 10 years old, is all it was removing the trapezium, applying traction, and then putting an anchor in the base of the second metacarpal, and then passing that suture through the first metacarpal to suspend it, right? Well, that's the latest Arthritis product, just kind of rebranded. And so the initial studies with this worked very well. I'm just going to plug it in my computer real quick with high satisfaction. But again, the issue was implant cost. When we talk about suture button suspension plasty, this is the tightrope. So this was eventually developed by Yao in 2010. It's undergone some iterations of design. The first issue was that they would use a bigger size K-wire. And so we had issues, there were issues with second metacarpal fractures. Now the latest generation has a much smaller K-wire and that has gone down significantly. I think the benefit of this approach is that you can get patients moving at 7 to 10 days, not 4 weeks. I think the downside or the biggest risk with this approach is it's easy to over tighten it. And if you over tighten it, patients won't be able to put their hand down or abduct to 90 degrees. And so one thing that Dr. Dalton taught me, which I use, is that if you're going to do this, you'll pass your tightrope, you'll do a single surgeon's knot. That's, maybe some slight traction. You want it to be a little snug, but then I will passively make sure the patient can get to 90, lie on the table, and passively flex to the base of the small finger. And then I'll tie the rest of the knots. I think if you ever see patients that are unhappy with this, it's almost always because it's over tensioned and it's easier to do than you think. When you look at biomechanically, it's stronger than LRTI and it's strong at time 0. They leave the operating room and it's strong and they can move. The reason why I rest them for 7 days is for soft tissue rest. When you compare it to other techniques using tendon, they have similar clinical outcomes. It's just faster. So whether you want to spend your money on OR time or on an implant is kind of up to you. I think one of the limitations of the suture button is cost. It's about $700 to $800 at my hospital. And this technique, which was pioneered by Del Signore in 2009, just using a number 2 fiber wire, takes 20 minutes and $20 and has the same outcome, where basically you're just doing 2 figure of 8s, creating a lasso between APL and FCR, which kind of prevents subsidence. And they compared these, and it's faster than LRTI with equivalent outcomes and immediate stability. Addressing above and below, so MCP hyperextension and STT arthritis. MCP hyperextension, how much is too much? This is kind of a moving target. I think, I initially was much more sensitive to this, but to be honest, a lot of patients that aren't bothered by a little residual MCP hyperextension, less than 30, I usually do nothing. If it's around 30, I'll consider releasing APB and anchoring it, maybe putting a K-wire. If it starts to get, greater than 40, you're thinking about an MCP fusion. There's a lot of techniques for this, but that's kind of my algorithm. I'm curious what some of the more experienced staff do with hyperextension. STT arthritis, so 16% radiographic prevalence, 40 or even higher percent intra-op. So every time I do a trapeziectomy, I always consent for it. I'm going to pull on the second metacarpal ray and look at the scaphotrapezoid joints. There's cartilage where I'll resect the proximal 3 centimeters of the trapezoid with an osteotome. If you look at outcomes, as I alluded to earlier, Cochrane Review will tell you that when you compare, now at this time I didn't compare the tightrope or any of the more modern techniques, but when you looked at trapeziectomy, LRTI, interposition, arthrodesis, total joint replacement, all the outcomes were similar. Pain relief, function, there wasn't a difference. And that's part of the reason why certain things like the hemiarthroplasty and other implant-based designs that are so expensive haven't really caught on, is because we have yet to show any, proven superiority of one technique versus another. So why would you spend that money on implant and take on that risk? So pain, no difference. Function, no difference. Trapeziectomy had slightly less complications. And complications that were looked at were things like hematoma, delayed healing, superficial radial nerve branch paresthesias. Late complications can be due to subsidence, although usually subsidence is not clinically an issue. Failure to address adjacent STT arthritis, incomplete trapezium removal, neuroma, painful pseudoarthritis, CRPS. These are some emerging techniques: the speed spiral, fat grafting, and denervation. The speed spiral is something that, a couple of years ago was really trying to get off the ground. It was kind of a ready-made anchovy. I think that kind of added to the ease and the expediency of the operation. The problem was the cost, which again, using a rolled up acellular dermal matrix, which is probably at least $1,000, is hard to justify, especially in today's kind of ASC environment. But there were good early results. As far as I know, this really hasn't made it to market. Fat grafting, PRP, it's more common in Europe, but there's some good evidence that fat grafting, especially with early CMC arthritis, can be helpful for pain. And then denervation, this is something that I'm hoping Dr. Graf can educate us on, because I think for the younger high demand patient, this is an interesting option that can treat their pain, preserve their trapezial height with little downtime. This is all over the meetings right now, but frankly, this is an old idea. It's 30 years old. Cozy described this in 1990 with good results. The issue has always been, congratulations, you denervated the joint, they don't hurt, but now they have a numb, patch of skin around their thumb that they complain about. So I think that as the techniques have improved and the outcomes have become more predictable, this will likely catch on, especially for early disease or someone that's not a good surgical candidate. So what are some conclusions? Tom, Joe, when you go into practice, start out conservative. If you meet someone and you sign them up for surgery within 15 minutes, you're setting yourself up for an unhappy patient. Always start conservative. Make them wear a brace if they haven't for at least a month, and do one injection. All the patients do an injection several times, and really until they stop working. These surgeries, are fun, and most patients do very well, but you have to make sure that the patient knows what they're getting into. This is not a carpal tunnel where 95% of patients at 3 to 4 weeks are back to their life and ecstatic. Many of these patients are going to be swollen and painful for the first 3 weeks. So you have to know going in. That's just as important when you sign them up, when you talk about the risks and benefits, is the rehabilitation and what to expect. So I'll tell these patients, we'll try to treat this with an injection. We'll try to treat you with the brace. We'll do some therapy. We have kind of low profile braces that patients like because they can wear them at work and stuff. And when these things stop working, we'll start talking about surgery. And with surgery, I personally do use the suture button suspension plasty. I'll say we'll get you moving at 2 weeks, but you're going to be sore and stiff for the first month. And really, it's going to be 3 months before you're going to be able to get back to most things, and even 6 months before you're not thinking about it when you're riding a bike or lifting weights at the gym or at work. And I think if you coach those patients, they actually get better sooner and they're happier. But the most unhappy patients, even if you tell them 1,000,000 times at the first post-op, say, you would never said it was going to hurt this much, or at 1 month post-op, man, like, you kidding me? Like, I never would have done this if I would have known it would have been my entire summer. So expectation management is something that there isn't necessarily a course on, but with good mentors, as you've had, as I've had, kind of helps set yourself up for success early on. When you look at surgery, as I said, trapeziectomy, hematoma extraction, arthroplasty, LRTI, all have a proven track record. LRTI has the lowest revision rate, but also the highest complication rate. So in conclusion, we've come a long way, but we haven't gone far. We're using the same Eaton Littler principles. We've just have a new emphasis on speed, patient recovery time, and technology over technique. I think we have to find a better way to measure success. It's not in an X-ray. We have to find a way that patients can reproducibly measure the success of an operation, that we can develop kind of randomized control trials that use things just besides pain and DASH. What normalizes biomechanics? What gets high demand patients back to high demand activities? We need to consider the cost of technology, especially when there's no unproven superiority. If you look at a suture suspension plasty, a fiber wire is $50, a tightrope's 800, and a joint replacement's probably several thousand. Show me how that, in the era of value-based care, show me why a joint replacement is better. The cost of OR time is about $100 a minute at our facility, and do you need general anesthesia? Some of these techniques you can do, under Wallent or MAC, right, in an ASC or an office setting. Morbidity, recovery time, salvage options. We need to choose a technique and discuss alternatives with informed consent. We need to broaden our playbook. It's not one procedure fits all. You have to understand your patient, understand the pros and cons, and ultimately pick the right operation for the right patient, and pick an option that's safe, cost-effective, durable, reliable, and patient-specific. And as we live in the era of marketing and new technology and innovation, that is critical to move the field forward. But we always have to ask ourselves, is it new and better or just new? And I think ultimately time will tell. So with that, I'm happy to answer any questions.
Thanks, Alex. I was just going to say, first of all, great seeing you. Hope things are going well up there. Thanks for putting this together. Like you said, this is a topic that has a lot of dogma associated with it. So it's good to kind of get back to the science and see what's actually data driven and what's not. So that was a really comprehensive review. Thank you for that. And my question for you is, in your practice, how do you approach the revision CMC arthroplasty, or even before we get to the revision, how do you approach the unhappy CMC arthroplasty patient? Let's say we're out of the subacute post-op period where you can tell them to just wait a little bit longer.
Yeah.
What do you try non-op there? And then when and if you offer surgery, what are your surgical considerations?
Yeah, so the first thing is you have to know why it failed. Did they fail because of subsidence? Did they fail because they have MCP arthritis or STT arthritis that wasn't addressed? So that's number one, figure out the source of failure. Usually it's obvious. If they have subsidence, they have subsidence. If they have MCP arthritis, your exam will tell you in imaging. When it comes to surgical technique, you use the opposite philosophy that failed the first time. So if someone had an LRTI, they subsided and failed, I'll use a tightrope. And I think we published a series of that in an RVA with Dr. Matlub as the primary author, and that seemed to work well. And conversely, if you have a tightrope that fails, rather you have, rupture of the suture, then I would do an LRTI. The beauty is with this is that there's multiple techniques, and that's generally how I approach it. If a tendon-based procedure failed with an FCR, I'm not going to harvest an APL and expect the same result.
Yeah, that makes sense. Thank you.
Thanks, Alex. Great talk. I was wondering if we could get a little more into the MP joint, your thoughts and some of the staff's thoughts. I feel like there's a fair amount of heterogeneity in terms of how aggressive folks are. You didn't mention the role, or if there is a role for capsulodesis in your practice or for certain types of patients. Or I don't know how you examine it, how you think about it vis-a-vis the patient's age and symptoms.
Yeah, it's a great question. There's certainly a role. I think if they're in like the 30-degree realm, I think it works well. It is another incision. I just think that I initially, and again, I haven't done hundreds of these like some of the people on this call, so I'll be very transparent with that.
I don't know that any of us have actually done hundreds of capsulodesis.
No, I just mean like CMCs, right? With MCP hyperextension.
We may have done 100. We may have done hundreds. I don't even know if we've done hundreds. We may have done substantially more CMCs, but I don't think anyone on the call has done a lot of fusion to capsulodesis, but we've done a few.
I just feel like, to be honest, as a problem, it bothers sometimes the surgeon more than the patient, especially with some of these lower demand older patients. Yes, if they have MCP hyperextension, it's going to limit their ability to grasp. The whole point is to improve function. But I think that if you just release EPB and pin it and it gets to neutral, I don't think most of them are very unhappy. Now, if you have a younger, higher demand patient, then yeah, I think that's the role. But I think early on, I tried to make everything fit by the book and make sure that I kind of thought more was more. And I think the pendulum has kind of shifted as I've seen my results and other results, that patients tend to do well with kind of a more minimalistic approach. And if you're there and you can just release EPB to limit the deforming force and put a pin in for 4 weeks and it's better, patients like that. And heaven forbid you make them too stiff or have a problem with the bigger volar procedure. I mean, it all depends on the degree of deformity in the patient, but I haven't had to do that in my first 2 years. The EPB release and the pinning has worked fine in my single digit N.
So Joe or Tom, what is difficult about the volar capsulodesis of a thumb versus, let's say, a volar capsulodesis of an MP joint of an index through small finger that you may do for clawing? Why is the thumb a little bit harder of a procedure?
Is the volar plate more, I mean, I would imagine it's more attenuated compared to other joints, particularly if it's been hyperextended chronically.
I mean, yes, it will be, but that's not the reason.
And then I find exposure challenging, but I did most of them as a resident. I don't think I've done as many capsulodeces as a fellow.
Joe, what anatomical issue do you run into that makes it hard?
Well, you're trying to work around the tendon insertions, I guess, is what's different than like other finger
Tendon insertions of
capsulodeces.
what?
So of APL and adductor, I guess, if you get all the way over to that side.
You're close. You're closer, but not quite right. It's the sesamoids. The problem is the sesamoids. You often have sesamoids on both sides of the volar plate, for where some of the intrinsics attached for the thumb, and therefore it can be really hard because they're often partially inside the volar plate, and so you have a very like narrow window that you're trying to create this like capsulodesis back down to. That is not. It's just not easy because you have a very narrow window that you're working in. So it's not like a super easy capsulodesis as compared to like one for, as I said, for like a Zancoli capsulodesis if you're doing for MP hyperextension, which by the way, Joe and Tom, we have one coming up. I think I have one coming up maybe before you guys graduate. So I'll let you guys know, but it's a little bit more difficult. And so interestingly enough, like an MP fusion is actually an easier procedure, as is what Graf said, which is just releasing the EPB and pinning it. So the capsulodesis is a little bit of a harder procedure. It's more finicky, is what I would tell you.
So answer the question, Chuck. When do you do capsulodesis? When do you do fusion?
Yeah, so there's an article out of Mayo, shocking, you know, that essentially kind of reviewed, it was like several hundred of them actually. And so anything less than 30, I don't do anything. Between 30 and 60, I'll give them the option of a capsulodesis. And then greater than 60, I fuse them. And then typically I give them the option of to do it simultaneously at the CMC when I do the CMC arthroplasty, or I give them the option to stage it if they prefer to see how they do. And if they have persistent issues, then I'll often say, okay, look, we can do a second surgery down the road. But out of all the ones that I've done, and I've maybe done, I don't know, maybe 4 or 5 capsulodeces, I've done probably triple that of MP fusions for the thumb. The MP fusions do really well, shockingly, even though it puts more stress at the CMC joint theoretically, it puts more stress at the CMC joint. Some of these people had such, 90-degree hyperextension deformities. They're just happy to have a stable thumb,
And so, Gotcha, when you say that the degrees, there's the papers that I'm familiar with, including the one you did, all rate degrees differently. Some rate it based off of what the degree is on a static X-ray. Some rate it based off of what the passive hyperextension maximum is, and some rate off of how much the active hyperextension maximum is. Which one of those do you use?
So that's a very valid point. I typically try and get them to like pinch and try and do it off of that and see how much, when they try and actively use it, how much it goes back. Because essentially that's what you're rating off of. Now, the other thing that you can try and do is that part of the reason sometimes why I like going dorsal, doing a dorsal thing, is that if you're doing something, you can tighten the APL a little bit to try and give them a little bit of a extension moment arm on the first metacarpal to try and lift that up to prevent that. But that's also kind of positioning of your implant. I mean, yet again, I will tell you, I've left several people alone that have a little bit of a hyperextension deformity, and they've done okay. And then, you know, you have the occasional people that you give them the option that I come back and done it down the road. But, you know, I'll be honest, I hate CMC arthritis as a whole. That's not to say we don't do it. I just, part of me, the thing that drives me insane is, you do a surgery, they're doing great, you tell them to stop therapy, or you tell them to watch out, they continue to go to therapy, they fall, you know, something happens, and then like sometimes you just can't get rid of their pain. And I'm like, I don't know what's causing it. I mean, I've had a lady who I think I'm sending to you as a second opinion. She has fallen 3 times on her thumb and ruptured the tightrope. I went in there to revise it because I was like, look, you subsided. And literally I just pulled the button and the whole button in the tightrope came out, as like she ripped it off. She like broke it apart. I'm like, we'll redo it. I've never seen this happen before, but you know, and the knot was intact on the other side when we went back. So I don't know.
You know what I do sometimes for some of these patients that you're just waiting until I have them fall and call you on a Saturday night is I'll do a little belt and suspenders with the tightrope and with the suture suspension. You know, it's an extra number 2 fiber wire, but I do think that, I mean, I would let them move 3 days later with that. I mean, I just trust it.
Yeah, I mean, that is the you know, not a lot of people have published on combination techniques, you know what I mean? Doing more than
I love
one technique.
that. I love the combo. And it hasn't burned me yet, but where I have seen the suture suspension, because it's so fast and cheap, people love it. But I have seen if you over tighten the hourglass, that FCR will rupture at the insertion, and they'll be like, you know, they'll be doing something and they'll have this acute pain. So I think it works, but that's Tom and Joe. I've seen that before at like 4 months. You think you're out of the woods and doing great, and then I think you can have ruptures of the FCR with that lasso. You just have to be careful. Use a taper needle. 2 passes, a 7 meter apart. Don't over tension it. It's really, that suture is really just a bridge, as a bumper to prevent subsidence. You don't necessarily have to have those tendons, you know, kind of kiss. You're just asking for tension and a problem, in my opinion.
So Alex, to Joe's question earlier, you know, we were talking about how you indicate someone potentially for revision CMC arthroplasty, and like your comment was, you know, well, if they're subsided on the X-ray and the problem subsidence, then you fix the subsidence.
Yeah.
And like, I feel like that's a little harder clinically though, when, as you mentioned, so many of them radiographically subside, and Dr. Gottschalk's saying how, you know, there is a like dissatisfied fraction of this cohort that is always going to be a little bit dissatisfied. Is there like a gestalt that you're getting for, you know, how much subsidence is too much, or is there an exam maneuver? Or
if they have a positive grind and they're subsiding, I consider that to be symptomatic subsidence. If they have
you go and revise it, Alex, or do you do anything else to prove to you that's not something else? Because I'll be honest, I think a revision CMC is a very difficult diagnosis to make on where it is. You could have neuroma, you could have subsidence, you could have tendonitis, you could have, you know, like first dorsal compartment tendonitis, you could have FCR tendonitis, you could have progression of SCT arthritis, you could have MCP hyperextension that doesn't actually show up unless you're like really trusting it. You could have a scaphoid problem that's happening, a radial styloid problem that's happening. That's a very difficult diagnosis to make, I think.
I think you could do a diagnostic lidocaine into the CMC joint space. And if you numb that up, like you put that injection in the scapho first metacarpal space, you go see another patient and come back and they feel awesome. I think there you go. But yeah, the problem is these patients will have, I mean, this is a very challenge like the CRPS population, right? Certainly I never rush into any type of revision surgery with these patients unless I'm confident it'll help them. And yeah, you do have to make sure. I would do that with that scenario. I would make sure that.
One thing I will tell you, Joe and Tom, that I found useful in these patients is just distraction, pulling their thumb and holding it out to length and seeing if that reduces their pain. And surprisingly, that has actually, for when I'm worried about subsidence, it's interesting, right? You're not worried about subsidence until you're worried about subsidence. And you're like, it's kind of one of those things where it's like, you're taught not to worry about it. And then all of a sudden you look at the X-ray like, oh, that's a lot of subsidence. And you're like, they have no pain. And then some people have pain. I mean, it can be very challenging, but I found that distraction works. And of course, everyone gets an injection prior to going to the OR. And I try and get them both a lidocaine injection and a steroid injection, plus minus, and see how they do. And I often will kick the can down the road for a while. I will say one of the reasons why I went to harvesting the full FCR whenever I do an LRTI, and I actually split it in half, one part for the actual suspension and one part for the interposition, was solely just to prevent FCR tendonitis, which you tend to, you have a higher risk of that if you just harvest half, but there's really not a huge difference of half versus whole. I just find that harvesting the whole one just tends to be a little bit easier just to pull it out and not have to worry whether you got part of it, how much did you get, is there still issues, you know. But the revision stuff is hard. I will tell you, this procedure will humble you later on in your career once you've seen enough and done enough of them, that when you have patients come back and they're not happy for whatever reason it is, you're like, you start talking more people out of it than you think, because you're like, you lay a lot of crate before they ever have it. And some people do so well, they're like, why did you tell us not to do this? I'm like, look, you're one of the 85% that's doing well. Just be happy.
The show the outcomes in the revision, there's a couple of revision papers out there. All of them show pretty poor outcomes. WashU has one, Mayo has one, there's a couple others out there. So revision is not an easy answer in this. And I agree with you, Alex. I think that diagnostic lidocaine injections are really helpful. And it's just hard because I've had patients referred to me for failed CMC that clearly had like stage 1 or 2 slack, that maybe that was the original problem to begin with, and they had the CMC that was the wrong diagnosis. So
the best patients take a bath with their cast on. I don't know if Mike remembers that crazy lady. You remember the lady that took a bath with her cast on?
They kept
I think it was in Wags' boards that the lady literally bathed in her cast and came back.
Yeah,
and
she did it again the second time after we washed her out and her dehiscence. She bathed again.
I will tell you, there's just, as I will tell you, this is, I've had my fair share of patients have major complications from this, where the tightrope has ripped through the bone, they've fallen afterwards or anything. So I would just tell everybody, it's a humbling procedure, and hopefully maybe one of y'all will invent something that you're like, hey, this works really well.
Yeah, I mean, I've changed what I do multiple times already. I did LRTI. I definitely have, I think there's some issues with that. I did the tightrope for a while. I think there's some issues with that. As Tom saw today, or as Tom and I did together today, I've gone, if I'm doing a low demand patient, I do like the suture suspension. I do tighten it more than what Alex recommended. I have not seen issues with FCR. I know Amy Ladd talks about that, but I think I have 40 or 50 now. I've yet to see an issue with it. I don't know. I'm not sure what the answer is. I do have to admit, the arthroscopic procedure, I think, is the most happy group of patients I've had up to this point. So I've definitely expanded the horizons on that. And since Alex was here, as Tom and Joe can probably tell you, I pushed the envelope on anybody who's remotely active now. One of the cool things that we're going to be part of, I don't know if Gottschalk knows this, but we are going to be one of the early release sites for one of the European implants that a large percentage of Europeans are using at this point. One Swiss surgeon's put in 3,000 of them already over the last decade. Every one of my friends who are Europeans at this point do it for everybody. I was just at the FESH conference, and I, out of curiosity, because I'm going to Geneva in December to sort of learn how to use this implant. And I was talking to multiple, the surgeons are basically our contemporaries. And I just asked them out of curiosity, what's your mainstay for CMC? Like, how often are you doing tendon-based procedures versus implants versus arthroscopy? And this is I was at the IWAS arthroscopy course. So we're presenting on arthroscopy. And all 4 surgeons that I was talking to, all 4 of them don't use arthroscopy anymore. They don't do OJ anymore. They do 100% of this implant. So it definitely made me convinced it's worth looking into. It seems like the Europeans have basically gotten rid of everything else and just gone to this implant. So I'm excited for that to finally come to the United States. It's not FDA approved yet. We're going to be one of the early sites and looking into that. I do think, though, I agree with Alex. Implants you have to have some caution with implants, and we'll see if this one stands the test of time. It's been around for about a decade in Europe. And America has been really shy at having implants because America is where a lot of the problems with implants came by. We were very aggressive in the 70s and 80s with CMC implants, and we had a lot of catastrophic failures. And I think as a result of that, our pendulum has swung to people being very, very cautious. I don't know. So it'll be interesting to see. But I can say, I think maintain trabecular height, there is something to that. I do think the arthroscopic procedure does that. And I think this implant procedure does that as well.
I would agree. I think the arthroscopic is the only patients that I'll do, like, I'll mobilize quicker. Otherwise, like if it's for LRTI, like I immobilize them for 6 weeks. And I think if you just, nobody does it, but if you did straight trapeziectomy, like I tried that early in my practice, it works, but you have to put the K-wire pin in for 6 weeks. Can't do it shorter than 6 weeks. So I really think like immobilizing them and not allowing them to use it for 6 weeks helps so that they prevent pinching. Because
Yeah, the only reason I got rid of doing that stuff is because the patients hated the K wires. I couldn't get the patients. They're like, when can we pull it? When can we pull it? I'm like, nope.
Yeah, it's like a problem, but that's why you just cast them. They never see
Alex, great talk, by the way. That was exceedingly comprehensive, very well literature supported, and fantastic job. I don't think Wags and I are very proud.
Yeah, you know,
The rest of the team.
Yes.
if I saw, I'm just grateful to be here. You know, what's so funny is like, you know, I see that chain email sent out every Sunday, and I've attended some lectures, and it's like this month you've had like, you know, Graham King talking about elbow arthroplasty. And it's like we're gonna have an international, regionally renowned person. It's like Alex Graf. It's just like complete crickets. So hey, I appreciate this opportunity. This is huge.
Yeah,
No, it's good.
Grateful.
It was one of the better talks we had. I thought you did a fantastic job.
Alex, plan to give another one next year.
Well,
Good topic.
Hey, do I need to send you a link for your and I's conversation after this?
Yeah.
Okay, I'll send you. I'll text you, or do you want me to text you or email you?
Just email it to me and I'll fire it up and I'll get my images for the boards up. I appreciate
Sounds good.
Yeah, no, I appreciate that, guys. Thank you. And Joe and Tom, I won't be there. I'm not moving to Athens until next month, but I wish you guys the best and welcome to the Emory family.
Good luck with the move. Thank you for a great talk. It was awesome.
All right, y'all take care.
Have a good night.